All right, nursing students, let's jump into some content about the neurosensory system. I'm Professor Heather Murphy, and I'm going to keep tying what we talk about back to patterns and keywords you might see on the NCLEX. So first, quick refresher. In a healthy eye, light travels through the cornea, pupil, and lens, then lands on the retina. The macula and fovea centralis handle sharp central vision. The rest of the retina gives you your peripheral vision. Keep that central versus peripheral idea in your head because NCLEX really leans into that pattern. Now, 3 big patterns to lock in: central vision loss, cloudy vision, and peripheral vision loss. Central vision loss, think age-related macular degeneration or AMD. Cloudy, hazy, blurry vision, that's your cataracts. Loss of peripheral, tunnel vision, halos around lights, that's glaucoma. If a question stem describes one of those patterns, your brain should automatically go, oh, that sounds like AMD, or cataracts, or glaucoma. Let's start with age-related macular degeneration. AMD affects that macula, so your central vision is impaired. Peripheral usually stays okay. There are 2 types: dry, gradual blockage over time, and wet, rapid, sudden growth of blood vessel that are leaking. The slides really emphasize the progression of AMD, where the central vision gets much worse. A classic tool here is the Amsler grid. Clients use it at home. It looks like a square grid of straight lines with a dot in the middle. Teaching point for clients: if they look at the grid and the lines are blurry, wavy, or distorted, or there's a dark or missing spot in the center, they need to inform their provider. That's a change in their central visual field. For AMD, there's basically no cure in what we've got here. Your goal is to slow progression and keep the client safe. So, safety is priority. Think fall prevention at home, good lighting, remove clutter and loose rugs, grab bars in the bathroom, non-slip mats, raised toilet seats, night lights. Nutrition-wise, the slides mention foods high in antioxidants like blueberries, grapes, spinach, zinc from red meats, dairy, eggs, and grains, and omega-3 fatty acids like salmon, soybeans, chia seeds, plus smoking cessation and blood pressure control. On NCLEX, if you see chronic, gradual central vision changes, use of an Amsler grid, and teaching about home safety and diet, that's dry AMD, or slow progression. Sudden big change in central vision, that's more concerning and needs to be reported immediately. Both types can be treated with intravitreal injections. The common medication for dry AMD is pegcetacoplan, which slows progression, and the common medication for wet AMD is anti-VEGF, which inhibits growth of those abnormal blood vessels. I know an injection into the eye sounds scary, but may be necessary to save vision. Now cataracts. With cataracts, the lens becomes cloudy and opaque, so patients describe blurry, hazy vision. It's usually painless and progressive. The lens can't bend the light clearly anymore, so things look like you're looking through a dirty window. Treatment is cataract extraction surgery. Pre-op, we want no illnesses before surgery and no blood thinners. Contacts are okay to wear before surgery per the slides. On NCLEX, when you see painless, progressive, cloudy vision in an older adult, your radar should go straight to cataracts. Post-op cataract care is super testable. Priority teaching: no strenuous activity, no straining, and no bending over. All of those increase intraocular pressure. Also, no heavy lifting, including nothing more than about 10 pounds. They should sleep on their back or on the unaffected side to decrease pressure on the operative eye. They must take the prescribed eye drops, and they should report any change in pain, vision, or drainage. We also use a protective eye shield after surgery, similar to glaucoma surgery post-op. And lifestyle: dark, UV-protected sunglasses and a wide-brimmed hat when they go outside. Foods high in vitamin C and E, like green leafy veggies, and smoking cessation. Here's your NCLEX strategy connection. If a question is asking which teaching to reinforce versus which to correct after cataract surgery, always pick the options that avoid increasing intraocular pressure. So no bending, no heavy lifting, no straining. If a patient says, I'll report sudden pain or decreased vision, that's good. If they say, I can lift my grandchild, or I'll sleep on the surgical side, that's something you'd need to correct. So anytime you see increased intraocular pressure answers, think bending, lifting, straining. Those are your red flags. Let's move into glaucoma and then retinal detachment. Both of these are huge for priority and who do you see first style NCLEX questions. So glaucoma is all about increased ocular pressure that damages the optic nerve. The big pattern: loss of peripheral vision, a halo effect around lights, and decreased visual acuity, especially in darkness. Think tunnel vision and halos. Diagnosis is with tonometry. Normal intraocular pressure is about 10 to 21 millimeters of mercury. Anything above or below that is concerning. There are two main types, open angle and closed angle glaucoma. Open angle is also called wide angle, and it's the most common. Outflow of aqueous humor is reduced, so pressure builds up gradually. That means vision loss is gradual. Clients might not notice until a lot of peripheral vision is gone. Closed angle or narrow angle glaucoma is urgent or emergent. Here, the aqueous humor flow is suddenly blocked, a complete obstruction, so vision loss is sudden. On NCLEX, that sudden severe eye pain, halos, and sudden change in vision with nausea sometimes implied, you prioritize that client immediately. Treatment-wise, the big categories in your slides are eye drops to lower intraocular pressure or surgery. One common surgery is a laser trabeculoplasty that uses targeted lasers to improve outflow and lower pressure. Post-op, the restrictions look a lot like cataract surgery. Avoid increasing pressure, and they may have a protective eye shield over the affected eye. Again, safety first. They already have vision loss, so fall risk is real. Now, retinal detachment. This one is explicitly labeled an emergency. The retina pulls away from the blood vessels in the eye, so that tissue is at risk for losing its blood supply. Hallmark findings: bright flashing lights, dark floating spots, and many clients say it's like a curtain or shadow coming over part of their vision. If you see those words in a question, flashes, floaters, curtain, immediately think retinal detachment and emergency surgery. Treatment is surgical, scleral buckle or pneumatic retinopexy. With the scleral buckle, a silicone band is sewn onto the sclera, creating a little indentation that supports the detached retina. With pneumatic retinopexy, an air bubble is used to help reattach the retina. Post-op, this is where positioning and restrictions become very testable. They're instructed to lay face down for about a week. They can be upright for ADLs, but the default is face down positioning so the retina stays in place. No lifting more than 15 pounds for 3 months. No water or contacts in the eye for 1 week. No driving for 2 weeks. An eye shield over the affected eye at night for 1 week. Sunglasses outside, and they'll be on antibiotics and anti-inflammatories. So let's tie this all into NCLEX priority thinking. When you get one of those multi-client assignment questions, you want to flag keywords: sudden, painless, and change in vision. Sudden severe eye pain plus halos and sudden vision loss, that's likely closed angle glaucoma, urgent. Sudden flashes of light, floaters, curtain over vision, retinal detachment, emergent, that's your top priority. Gradual central vision loss in an older adult using an Amsler grid, that's AMD, important but not first in a 4-client list. Painless, progressively cloudy vision, cataracts, again, chronic and not your emergency. So on NCLEX, when you're asked, who do you see first? Go for the words sudden and change, especially when they're paired with pain or a new visual disturbance. Chronic, long-standing issues usually get scheduled follow-up, not immediate action. Let's switch over to the ears and wrap this up with some hearing and balance content. Quick anatomy refresher. You've got the outer ear, the middle ear with the eardrum and ossicles, and the inner ear where the cochlea, vestibular nerve, and semicircular canals live. Those fluid-filled semicircular canals help with balance. The cochlea handles hearing. Hearing loss can be sensory neural, conductive, or mixed. Sensory neural is often from aging, noise damage, explosions or blasts, basically damage to the inner ear or nerve. Conductive is more about a problem getting sound into the inner ear, like fluid, a foreign object, or a ruptured eardrum. Mixed can come from infections, trauma, or genetics. Ototoxic medications are also listed as a cause of hearing loss in your slides. So on NCLEX, if you see a med history plus new tinnitus or hearing changes, that's a big clue. Diagnosis can use audiometry, simple bedside things like the finger rub test or whisper test. Typically, high-pitched sounds go first, which leads into complaints like, I hear you but can't understand the words. Tinnitus. That's the perception of sound like ringing, buzzing, hissing, or roaring when there's no external noise. It can be constant or intermittent. The slides even show a tinnitus screener where they ask how long it lasts and how often. When it's chronic, it can be really distressing. Treatments in your material include hearing aids, cognitive behavioral therapy, tinnitus retraining therapy, and acoustic or sound therapy, like white noise or music. The goal is to mask the tinnitus so it's less noticeable. On NCLEX, be careful to eliminate distractors that ignore safety or scope, so don't pick options that tell the nurse to prescribe new meds or promise to cure tinnitus. Look for realistic nursing actions, teaching, referrals, and strategies to cope or mask the sound. Meniere's disease is another classic. It's a progressive disorder from excessive buildup of endolymphatic fluid in the inner ear. That leads to the triad of debilitating vertigo, tinnitus, and hearing loss. Risk factors can include inadequate drainage, autoimmune disease, viral infection, and genetics. Treatment from your slides. Medications like meclizine, antiemetics, and diazepam, plus a low-sodium diet and diuretics. Low sodium helps reduce fluid buildup. On NCLEX, that combination of vertigo, tinnitus, and hearing loss plus low-sodium teaching should scream Meniere's to you. Also think safety. That vertigo makes them a huge fall risk. We've also got common ear problems. Otitis externa, outer ear, often called swimmer's ear. It's tender to touch, but less likely to be deeply infected. Teaching. Dry the ear after swimming, use alcohol-based solutions if ordered, and no cotton tip swabs. Otitis media is fluid behind the eardrum. If it's infected, we use antibiotics, pain relief, and sometimes cerumen, wax, removal. Tympanostomy tube surgery is used for chronic issues. A ruptured eardrum is a hole in the tympanic membrane. The client often feels sudden pain relief when it ruptures. It usually heals on its own within a few weeks, but can result in some hearing loss. Again, from an NCLEX standpoint, you're looking for teaching that protects the ear, prevents infection, and respects healing, not putting anything in the ear canal unless prescribed. Cochlear implants are another big neurosensory item. Components in your slides: a microphone, a sound processor, a headpiece, an implant with an electrode system that stimulates the auditory nerve near the cochlea. Post-op care. Avoid strenuous activities. Lie on the unaffected side when sleeping, and use soft foods with no straw. No straw helps avoid pressure changes. If you see a select all that apply on cochlear implant teaching, you'd select things like avoiding strenuous activity, side lying on the unaffected side, and soft foods without a straw. And you'd skip anything that suggests manipulating the surgical site or resuming heavy exercise right away. NCLEX-wise, neurosensory select all that apply questions love to mix correct and incorrect teaching. Your job is to pick the options that match the slide content: safety, fall prevention, correct positioning, and realistic expectations. For hearing loss and tinnitus, that means strategies like hearing aids, sound therapy, and coping skills, not miracle cures. For Meniere's, think low-sodium diet, meds like meclizine, and safety with vertigo. For cochlear implants, think post-op protection and positioning. If you focus on patterns, central versus peripheral vision, chronic versus sudden changes, vertigo plus tinnitus plus hearing loss, and safety first, you're going to be in great shape for NCLEX neurosensory questions. It has been a pleasure having you in MedSurg 2 class this semester, and I know you will do great on the exam and ultimately the NCLEX.